Okay everyone, we're here for the last video on derm. I don't know about you, but I'm getting a little tired of derm. We're going to be talking about vascular reactions of the skin. So the first thing we're going to talk about is urticaria and angioedema, which is that swelling of the deeper tissue. And these are caused by a hypersensitivity reaction, usually a type 1 reaction to IgE, and that's commonly known as hives. So as we said, hives, urticaria is a superficial dermis swelling, and angioedema is the deeper tissue and the subacute swelling. With urticaria and angioedema, there is a complex antigen-antibody response where histamine is released. Other mediators include the leukotrienes and the prostaglandins. You may see vasodilation and increased vascular permeability. Some possible causes for urticaria and angioedema could be reactions to foods, bug bites, stings, parasites, or pollen. Could be skin coming into contact with different chemicals, latex products. Could be fish, or could be exposure to capillaries. Could be a response to a bacterial, viral, or fungal infection, especially those of strep or sinus infections, mono, adenovirus, or the enterovirus. Could be a cholinergic response to a physical stimuli such as the heat, the cold, the sun, or water. Could be reaction to drugs. About 10% of urticaria is usually acute in nature and can be seen with salicylates and penicillin as the two most common agents. Can be genetic in origin. It can be seen concurrently with an inflammatory disease, such as inflammatory bowel or a collagen disorder. It can have an immunological cause, but that is rare, and then also it can have an idiopathic or unknown cause. On your clinical findings in your history, you want to assess if there's been any family or previous history of these conditions, if there's been any atopy, which is an itchy inflammation of the skin. Has there been any itching? Has there been any ingestion of food or drugs, or injection of any agents that could be causing the issues? Any infections? Any inhalation of dander, pollen, dust, smoke, or aerosols? Any recent bug bites, animal bites? Any change in cold, heat, exercise, sun, water, pressure, or vibration? On physical exam, you're going to notice that urticarial rash, the hives. The location of lesions may indicate where the causing agent was exposed. With angioedema, you may see involvement of the upper airway, and this could be life-threatening. There are no true diagnostic studies, but you would refer to an allergist if possible anaphylaxis was noted for increased testing. Differential diagnoses could include contact dermatitis, atopy that we talked about, erythema multiforme. Management includes identifying and removing any offending substances. If the child was on antibiotics, it would be important to stop that antibiotic to see if it was the cause. Important to avoid any possible food or environmental triggers. Management would also include the use of antihistamines such as Benadryl or Vistaril to help with itching and hives, and until those are resolved. The non-sedating antihistamines are less effective, but if needed, cetirizine, loratadine are best. The urticaria is less likely to reoccur if antihistamines are used for 1 to 2 weeks after resolution. Topical antipyretics may be helpful to the skin. If there's concern for the degree of the urticaria and angioedema, then use of epinephrine is indicated. And then prednisone can be used for a week with a rapid taper if other treatments have been refractory, or if angioedema is present with swelling of the lips and face. It's important that you assess for complications such as anaphylactic symptoms or any serum sickness. Serum sickness may begin with hives but has other systemic symptoms such as fever, arthralgias, malaise, lymphadenopathy, and protein in the urine. If the urticaria was found to be caused by a drug, trying to re-challenge with that drug is more likely to cause anaphylaxis the second time. It's important to educate your patient and family on the causes, the course, and the treatment that is expected to be beneficial. Most episodes resolve in 24 to 48 hours, but can and rarely extend beyond 3 to 4 weeks. Follow-up evaluation won't be needed unless the urticaria lasts longer than 8 weeks. It's important to avoid the allergen and wear a medical alert bracelet and refer for hyposensitization if there's life-threatening symptoms, and it's important that this person carry an EpiPen. Okay, let's talk a little bit about erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Erythema multiforme is a distinct disorder that does not progress to Stevens-Johnson syndrome or to toxic epidermal necrolysis. It usually is a benign, self-limited acute condition that is characterized by targeted lesions and mucosal involvement that may be seen as papules or varying size bulla. It is rarely associated with complications. Stevens-Johnson syndrome and the toxic epidermal necrolysis represent a distinct syndrome that occurs when where there can be a continuum of symptoms. Erythema multiforme usually follows an infection and can be recurrent. Approximately 80% of these cases are attributed to the HSV virus, in particular herpes labialis. The herpetic lesion can be healed, but or have a subclinical presentation, and this can lead to an immune response by the body. Erythema multiforme may also be associated with other viruses such as the Epstein-Barr virus, cytomegalovirus, and the herpes viruses. So on your clinical findings for your history for the erythema multiforme, it's important to assess for any recent or current infections, exposure to ultraviolet light, trauma to any particular area, low-grade fever or malaise. With Stevens-Johnson syndrome or the toxic epidermal necrolysis, you want to assess for medications. Stevens-Johnson's may be caused by a virus, and you may note fever, sore throat, and arthralgias with the Stevens-Johnson syndrome. On physical exam with erythema multiforme, lesions may vary with each episode and may be different from one patient to another. There could be dusky red macules that evolve into larger target lesions with multiple concentric rings. There could be fixed, symmetric, they can be found on the face, the extensor surfaces of the arms and the legs, the dorsums of the hand and the feet, and the palms and the soles. But most commonly, the oral mucosa is involved. The clinical findings for Stevens-Johnson syndrome are erythematous macules on the head and neck that spread to the trunk and the extremities, blister formations that appear within hours and can be hemorrhagic. You can see mucosal involvement of the eyes, nose, and the mouth. In the toxic epidermal necrolysis, you have rapidly coalescing targeted lesions that with widespread bulla. You have full thickness epidermal peeling within 24 hours. The conjunctiva, the urethra, the rectum, oral and nasal mucosa, and the larynx may or may not be involved. Care for these conditions, especially we'll start with the erythema multiforme, are supportive. It's usually a self-limiting condition. You can use mild analgesics, cool compresses as oral antihistamines, topical intraoral anesthetics, or debridement with hydrogen peroxide for those areas that may be sloughing, wound care if needed, IV fluids if dehydrated, and systemic antihistamines, analgesics, and antimicrobials if symptoms have worsened or are not managed by the above. With Stevens-Johnson's or toxic epidermal necrolysis, it's potentially life-threatening. There'd be hospitalization to an ICU, a burn unit for IV fluids, and IVIG to help with the immune response. Okay, next we're going to talk about papulosquamous eruptions of the skin. The first is pityriasis rosea. It's a common, mild, self-limiting condition. The true definition of the word is rose-colored flaking. It is a minimally contagious condition and occurs most commonly in the fall and early winter and spring in temperate climates. And 50% of all cases occur before the individual is 20 years old. With your clinical history, it's important to assess for any mild symptoms with this condition. A small percentage, approximately 5%, experience a prodrome of mild symptoms, including malaise, pharyngitis, lymphadenopathy, and headaches before the rash occurs. So it's important to assess for those. On physical exam, you will find a Herald patch, which could be a 2 to 5 centimeter solitary, slightly reddened lesion that has scaled, lightly elevated borders that enlarges quickly with central clearing. These can typically be found on the trunk, the upper arm, neck, or the thigh. They take on a pale pink appearance. You may note that they take on a Christmas tree pattern of distribution. The lesions can be itchy. Differential diagnosis includes psoriasis, nummular eczema, and scabies and tinea. Management includes calming agents for the skin, such as calamine lotion, Aveeno, antihistamines, and emollients. You need to avoid sun exposure at this time, as it could aggravate the rash, and oral erythromycin may hasten the resolution of the rash. It's important to educate your patient and family that pityriasis rosea has 3 cycles: an emerging, persisting, and a fading, with spontaneous resolution typically in 6 to 12 weeks. You're going to note transient pigmentary changes, especially in African Americans, and recurrence is common. Next, we're going to talk about psoriasis, which is a skin disorder that is characterized by thick silvery scales with various distribution patterns. There are different types of psoriasis, which include a guttate psoriasis that follows a streptococcal infection, a psoriasis vulgaris, or napkin psoriasis, which occurs in the diaper area, an inverse psoriasis, which is limited to areas that are normally spared, and localized pustule psoriasis, general pustular or psoriatic erythroderma, and as becoming more popular that you hear on TV, psoriatic arthritis. So we know that this is an immune-mediated disorder that has a genetic disposition and also is affected by environmental factors. On your history, it's important to note if there's been any family history of this condition, streptococcal infections, trauma before onset, or any information offered on itching. On clinical findings, you may note issues at the scalp, elbows, knees, and buttocks. Those are the most common sites. Plaques can be discrete, symmetric, well-marginated rash becoming papular with silver scales. If it's a guttate psoriasis, it's teardrop in appearance. It can be widespread, symmetrical, round or oval lesions on the trunk or on the proximal extremities. For psoriasis vulgaris, it's well circumscribed, reddened plaques that have thick silvery white scales on the elbows, the knees, the scalp, and the hairline. There is a condition called the Koebner phenomena, and it's lesions that occur in an area of an injury. If a scale is removed, there can be bleeding, and this is called an Auspitz sign. And then we talked about the napkin or diaper area. Diagnostic studies include an ASO if it's in a guttate pattern, or a KOH scraping to rule out a fungus, and then VDRL to rule out secondary syphilis. Differential diagnoses include seborrhea, candida, dermatitis, and atopy. Management includes sun exposure in moderate amounts. These often help alleviate lesions, but it's important to prevent sunburn using emollient creams for the skin, topical steroids. If there's psoriasis in the hair, tar or a catalytic shampoo. Mineral oil often will soften the plaques, and there may need to be a referral to a dermatologist. Complications can include a candida infection. There can be erythrodermic or pustular psoriasis, and exfoliative erythroderma, and psoriatic arthritis. It's important with patient education to make them aware that there can be chronic conditions with remissions and exacerbations. The guttate psoriasis often resolves with antibiotics. Lifestyle changes are needed to help prevent reoccurrences. This condition can improve in the summer and also can improve with pregnancy. Next, we're going to talk about lichen striatus, which is not necessarily common in childhood, and is characterized by unilateral shiny papules along the embryonic lines. And it's a cutaneous defect from embryological mutation. It's most common in school-age children and affects girls more than boys. It's typically located on the extremities, the upper back, or the neck, but can be found on the palms, the soles, the nails, the genitals, and the face. Lesions spontaneously disappear after 3 to 12 months, but may last up to 3 years, and there can be short relapses. On your history, it's important to note if there were any spontaneous appearances. Physical exam, we talked about the linear, shiny, hypopigmented areas, and differential diagnoses could include lichen planus and lichen nitidus or psoriasis. Management, it resolves without treatment in usually 1 to 2 years. Lubricant or topical steroids help reduce the scales and inflammation, and it's important to educate the family that it's a benign, self-limited condition. Keratosis pilaris is found on the extensor aspects of the extremities, the buttocks, and the cheeks. The skin has the appearance of chicken skin with small bumps at the hair follicles. It is common in children with atopic disorders. It's important to assess for a spontaneous appearance. On physical exam, you're going to note rough, dry skin, small papules. Diagnostic studies are typically not needed, as clinical presentation is pretty easy to determine based on skin findings. Management includes lubricants, emollients to moisturize, topical cherolytics, and antibiotics if folliculitis occurs. Okay, at this point we're up to congenital lesions of the skin, and I'm going to let you read about that in the book. If it's pretty self-explanatory, we're going to talk more about nevus and vitiligo and various hair and nail disorders. So I'm going to let you finish that in the book, and I'll close out this chapter. So there will be 5 videos for chapter 37. Just wanted to make you aware. Thank you for your patience, and I'll have chapter 24 up soon.